that the webinar is being recorded and that we will archive the webinar on beforeandbeyond.org in our preconception infant mortality CoIIN section. And we will be sure to send you information about how to access this recording and some of the other webinars in our series. As just a review of our project, so our goal for our preconception CoIIN is to develop, implement, and disseminate a woman-centered, clinician-engaged, community-involved approach to the Well Woman Visit to improve the preconception health status of women of reproductive age, particularly low-income women and women of color. And as we're seeing all of the stories unfold, it's really exciting to see those words and that goal really come to life. So our agenda for this session is I'm welcoming you, and again, so glad you are all here and making the time for this. We are then going to hear from Mary Webster, who is going to talk with us about running Pdsas during COVID-19, which we've heard from many of you as challenges. How does one keep quality improvement going? How does one keep projects going in a time of really interesting change? So I'm excited to hear from Mary. And then after that, we will just take a little bit of your time to just be thinking about some of the next steps for our CoIIN as we look forward to the next 6 months or so that we have together. So I just want to take a minute and introduce Mary. I can say that the UNC team has really enjoyed the opportunity to work with her as our quality improvement coach. So Mary has her master's in nursing, and she's a registered nurse, and also has certificates in, I'm sorry, I'm forgetting what
healthcare quality
stands for. Thank you. Yeah. She is the Senior Program Director for Population Health Improvement Partners, and she is the Data Team QI Coach for the Infant Mortality CoIIN project overall. She has over 14 years of experience in quality improvement training, leadership, and coaching for statewide and national improvement initiatives. She's currently providing coaching for 2 of the national CoIINs, and is in the process of developing a QI training program, and also working with a practice-based collaborative for a project for children and youth with special health care needs and medical home. She is impassioned about coaching interprofessional work teams towards improved health outcomes, and we're very excited that she is a North Carolinian. She lives in Calabash, North Carolina by the ocean, along with her husband, 2 cats, and 3 adult daughters, for which she is very proud. So Mary, excited to have you here, and I am going to turn it over to you. Mary, we can't hear you.
That's what it was. You need to unmute me.
Okay, there we
talking
go.
Away. Yeah, okay. Good afternoon and good mid-morning to everybody, and thank you so much, Sarah, for introducing me. And I was looking at that picture a little while ago. I said, well, I look alike, but I look about the same, but a lot more gray, unfortunately. So one of the hazards that come from COVID. So today we thought it'd be fun to talk about Pdsas. And you say fun, talking about Pdsas. Well, for those of you that have had a chance to get to know me, you kind of find out that I think that way. I think in Pdsas all the time. And once I learned about them and learned about quality improvement science, I jumped in the deep end right away and it kept swimming. But we are running Pdsas all the time, every day. Just getting up today, I bet you had a couple that you did. And I hope as we talk for the next few minutes that you'll start to see that and be proud of yourself for the work that you're doing right now. Let me just keep moving here. So here's
sorry, Mary, this is Catherine. Could you maybe adjust your mic a little bit? Belinda is indicating it's a little difficult to hear.
Okay, is that better? I hope, Belinda. Let me know if it's not.
Yeah. Thank you.
Oh, yes. Please, everybody, please feel free to say stuff like that. We're going to go over the benefits of PDSAs, reflect on recent pivots, and consider ways around communicating your project learning. So we're going to do a little poll here, and we're interested in seeing how you have adapted your work in recent months. And I've given a few options here, and go ahead and check off, if you can, if you're at the computer, and check off which ones apply to you. You can check off one, or you can check as many as apply to you. I think we're almost about done. Okay, so Catherine, they can see these results, correct?
Yeah, they should be able to.
Okay, so this probably isn't a shock to most of you that, you know, we had about 74% of us working from home now. About 90% are doing these lovely Zoom work meetings, teaching clients and kids. And what I meant is, like, I have some colleagues that are, you know, having to homeschool while still working. That's been a challenge. And then I love to see that 57.8 of you were ramping up on resource availability and knowledge, so taking advantage of some of this time to see, well, what is available now virtually, even for ourselves as workers and our clients and maybe our teammates or coworkers. Just a few of you changed your hours of work, and let's see what else was and the telehealth. I was interested to see how many of y'all are doing that. So I'm glad to see a quarter of you are out using it now for patient and family education. So that's kind of neat. Okay, great. Thank you. Okay. A lot of adoption there and adaption. So why Pdsas now? You know, we're in the middle of a lot of change, and you're thinking, oh, goodness, really, do we need to be testing things? Well, actually, it's rapid learning during rapid time. So actually, the Pdsa cycle is perfect, even more perfect now. Smaller tests for high-risk times or events, that's really sound to do it that way, because you're taking, these are high-risk times. You know, maybe you are meeting with someone over the phone, seeing a client or patient via telehealth, and you've not really shored up your processes around that, so that may be considered high risk for you. So testing little things at a time is wiser. It can maintain staff momentum in your project, and we'll talk a little bit more about that too. We are innovating very rapidly right now, and mainly because we've been forced to make changes all around in the way we do. You know, there's new talk of the new normal now, not going back to normal, but a new normal. And then also Pdsas are a sound practice. So plan, do, study, act cycle, or test of change, small test of change, you might have heard it that way. Very familiar to many of us. I know that there's probably not one person on this call who has not heard of that. Most likely you're doing them. I'd be surprised if you weren't. And but sometimes we think that you know, we don't want to do them because they're big. They're big things to do, but actually they're really small tests. And it's iterative learning at its best, one thing after another. So I immediately, when I think about teaching Pdsas or trying to get an analogy for them, I think of riding a bike. You know, I don't know if 100% of us have ridden a bike before, but a large majority have probably either ridden yourself or had a child, maybe a grandchild you were teaching to ride a bike. And there is learning that has to be done. Very rarely does someone get on a bike and take off the first time. So think about your process or the process that maybe you've watched over time. So, you have to consider how to do it. You may have a friend or a mentor who showed you first. And we do that with our work that we're doing now. We've looked at other centers. We've looked at the other state teams. How are you doing those things? And then we go through the process again. We may just get up off the curve and fall over, and then we think, okay, that didn't work too well. What can I do differently the next time? Should I start with with the pedal and my foot up on the pedal? Should I start on the seat, or should I start with both legs down and one foot? So we try different things. We do it, and then we analyze whether that worked or not. And depending on that analysis, we go forward and either augment it or change the way we're going to do it, or we say, well, that didn't work. So we try something completely different. But I do want to comment on things called failed Pdsa. So if you ever done one and you think, well, that didn't work, that was a mistake, it's not a waste of time because you learned something for one thing. And then you may have to think about your conditions. So maybe it wasn't a good first bike. Maybe it was too big of a bike or too small. Maybe I had a wet driveway and it wasn't the best conditions for that. Maybe it was too large of a test, meaning like the bike, I was trying too much in one day, so I got frustrated. So I know I learned better in a slower environment. So all those things can be taken into consideration before bagging something. So remember way back when it was January and February, we can remember back then. Think about the status of your prototype, your interventions, client-provider interactions that you were having, some system changes that you were starting to either think about or try. So just take a moment to think back. Maybe you were starting to work with your IT department about an EMR adjustment or a template development. Were you thinking about embedding questions for pregnancy intention in your work and where that would go? Maybe you were already doing it. Things were kind of moving along here. And, and as those of you who participated with Giselle have already been doing that reflection, thinking back about what your story is looking like so far and all the things that you've learned and tested. So did it look like this when you think back? Is this what you saw in your mind? Was it nice and smooth? Things were, moving along. This is Class 1 Rapids. I don't know how many of you have done whitewater rafting. I've done it several times, and it can be exhilarating and scary, and I remember the first time, and it was, really scary, and there was a lot I had to take in. But, maybe you look back and you think in January, February, it was quite smooth sailing, maybe a few hiccups, maybe a few adjustments you were making, but you were learning some from your peers and your clients. And then then there were things we were also hoping to experience as we coast down the river as a team. Ooh, the sound is getting weird again.
Can I just, Mary, just if everyone could please take a moment to make sure your computer speakers are muted if you joined by phone. And also if everyone is able to please make sure that you mute your phone line or your computer microphone if you're not speaking. We unfortunately can't mute folks today. So if you could do that, that'd be great. Thank you.
Okay, I'll try again. So think about the one thing we were hoping to experience from January and February was looking forward to our meeting right now, which would have been not on Adobe, it would be in person. So those were the things that we were kind of thinking about and testing along. But does it look or feel like this now? This is your Class 3 Rapids. And, I'd love it if you chat in, if y'all have done these rapids before and some of the feelings that you had either in the beginning or as you were going through it. And then as we go further in the talk, what it was like at the end, because I'd love to hear others who've experienced this. But right now, this is what I thought of when I think of the COVID situation, and even with Pdsas and what your experiences might be, that, there's constantly changing environment. Your team is working harder than ever to make sure that you're communicating changes, but you may feel like you're not even able to even really do that. Like, what way do we do it now? There's things are changing. We're doing contingency planning. It's not as comfortable as with the Class 1 rapids. Things aren't as smooth. They're still busy, but we're having to adjust a lot of workflow. And then during this part of the rapids, your skill set for making adaptations is really getting honed in. You're listening more. You're seeing, you're testing, you're doing. Opportunities there arise to do things differently than you did in Class 1 rapids. So things are arising for you to look at it differently, think about it differently. Also, when you do think about the adaptations that you've made so far. You can think back to the poll, and there are probably some others that weren't even listed there. So maybe they were thought out. You had to think about the adjustment, like switching to working at home, let's say. So you had to make some plans. You executed things quickly because they might have expected you to be able to do it like the next morning. So you had to make some quick adaptations and quick thinking. You made some changes and adaptations based upon your own feedback, like how did that feel, how did that work, or maybe your patients were giving you feedback if you were talking with them. So that was that studying. And then you tried it again the next day. Maybe you made a few tweaks. You decided to move your computer in another area of your house. One I constantly have been working with lately is figuring out how it doesn't look like always that my ceiling fan is coming out of my head. So those are constant changes, Pdsas for me. So again, my Pdsa during this time too is incorporating, more evening exercise, especially on the days that I'm on the phone all day. So, I need to get that in. So figuring out ways to do that versus, the inclination for couch time. So think about some of the things as we go forward that you're working on. So we are interested in this, and please use the chat function for this, but what have you translated over to now? So thinking about where you were working in January, February, December, last quarter up until we ended up having this March change. Maybe it was ensuring clients access to essential services. Was this something you've had to translate over into your new normal? Continuing to ask reproductive intentions, maybe even during a sick visit. Maybe you never did that before, but it was seen as an opportunity now because you're like, ooh, I've got this female here and this patient is for a captive audience. How can I get this conversation in? What about EMR optimizations? Have we thought about that? Maybe it's like, after I've been doing it this way for a while, this would make it so much easier. So if you have some things that come off at the top of your head, take a moment to chat those in, because this is a great time that you have to share your learning with each other. And we don't get that a lot. And you may have that one idea or that one change that you made that could really help someone else on the phone. So don't be shy about adding what you've learned or what you are learning and translating over. So we have to go into data collection. And, I found that when this first started back in March and even into April, there was a strong, overwhelming inclination to put brakes on things. Like, ooh, I can't do that. I can't look at that. I don't know how to do that. Some were, real problems, like they couldn't access the data from their home computer anymore, and some special protections had to be added that hadn't been added quite yet. So there was a lot around data, but there are things that have switched and can switch, so you feel like you're still keeping a pulse on what's happening with your project that you're working on. You don't want it to be a burden, of course, anytime you do data collection, but it still can tell us if the things that are important to you, procedures, care delivery, is still working and still happening. If measuring 4 things, maybe you had to stop them due to changes, but is there one measure that could be easily tracked from your new normal that would give you information that's, good enough, or it's keeping us on track? It tells you a little snapshot of your system. So here we're talking about, what essential information are you still getting? Maybe you've had no disruptions and you're still getting reports, you're still able to, that's great. Does it fit in with what you were collecting pre-COVID-19? So is there any adjustments you've had to make? Maybe what you're doing now is no changes there. What can you still collect that's not burdensome? And I'm not saying that what you were collecting before was burdensome, but maybe you've had to make so many adjustments in your work that you have to scale down, but you still, for this temporary time, want to make sure things are still working. So what could you still collect? Maybe it's qualitative data now. Maybe it's a comment from a patient that, every time you hear it, you record that. What about new interventions that you want to see more of? Now, that's the million-dollar question for a lot of us, is what is going on now that we have seen the light bulb and we know that either made our work better, our patient's life easier. Maybe I've heard from being on calls like this that they're getting more time with patients and families. They open up pretty easily on the telehealth. Maybe they're open to learning, doing a class online that they never thought they would before. So what about those new interventions? And why would we want to make sure that we note that? So thank you, everybody, for continuing to write in the chat. Back to the innovations that you're discovering, any pertinent data that you're collecting, all that stuff, again, is wonderful. So I was just seeing one comment here from Rocio. It's like, quickly learned and utilized Facebook Live to educate community. Okay, now I love how you said quickly learned. So I think that we can all relate to that. Everybody's had to about pick up something new pretty quickly. And maybe you never would have ever believed you would use Facebook Live to do an education event. And now you're like, hey, this wasn't so bad. I learned it quickly. I think we can do this. I think it can meet some needs. We may not always do it 100% of the time when we go back, but maybe I'd want to try it on a part-time basis. I need to get some data about that to see how the families or patients feel about it. So when we go to, doing these testing and adaptations that you're doing all the time, and just kind of remember that, finding options, learning, recording, all that kind of stuff. And I'm going to bring up these words quite a bit because there's a pattern to that. So Ellen, I wanted to just mention some of these. Ellen brought out increased opportunities to clients to determine their preference for receiving care. So virtual, phone, in person, valuing the patient, client's time and priorities. And, we are all patients as well, one time or another in our life. And if I read that, I would say, wow, for me as a patient, I'd like to be asked what my preference is. And maybe before in the way you delivered care, there wasn't an option to do that. But maybe now there will be, continue to be that way if we can work it out and have some data behind that. So do think about what would I need to collect, and not to be burdensome, but what can I collect along the way to show that that change is an improvement. So communication is very key, as you know. It's something that we all have to work on constantly. We're not perfect at it by human beings. But I would love to know what you've tried so far to keep your teams engaged. So, finding an option virtually or via huddle on a phone or email huddles. I've done those before. Every day at noon we'll get on the email and put in our learnings from what we tried today. Find out what works and doesn't work, but, don't give up on that. So do test something that others may want to know about it. So did you test something, So did you test something that you thought was pretty novel, but, there's a good chance that someone else would like to know about that. So let them know your findings. Are you gathering pertinent anecdotal information from stakeholders or patients that would be helpful in your on your I Am CoIIN story? Have you made adaptations that has made your work easier? We brought that up before. Share that news. It's important that you celebrate all your learnings, big or small wins, sometimes small wins more particularly. And that's part of the adaptiveness and resiliency that we brought up earlier in the talk. You are resilient. You've learned that in your skill set over the years and your adaptation. That's not new. You've been doing that. But I bet now it's time to really highlight that. So guess what? When you plan to bring all those new learnings, procedures, et cetera, back into the clinic or your office space, the Pdsa can come to the rescue once more. So you may see where I'm going here. We're constantly, like I said, we're constantly doing them. And the key is, of course, to have a plan and get that learning documented and disseminated to care teams, clients, partners, stakeholders, office mates, because remembering back won't be so easy. I have a hard time remembering yesterday. So, remembering back 6 weeks ago, if somebody asked me what I was doing in March as far as my new learning, I'd have to hope that I put something down somewhere, right? So the communication and the recording of that work and that learning is very important, be it a journal or during staff meetings. Maybe that's a new item on your agenda, is the new learning. And, set the stage that, it's all learning. It's nothing good or bad about it. It's just all learning there. So Julie said that they're still able to ask most of their screening questions from the screening tool. They are not being asked as often because of the time it takes to ask over the phone, and asking verbally isn't ideal. But the questions are still being asked some. So thank you for that, Julie. And that speaks to, you've had to adapt it. You've had to scale it back because of the new venue of the phone. And, I think this one is a perfect example where you can gather with your team or, with your coach and say, let's talk about some other ways that we make sure we get the essential questions in a safe way, that we tee up our patients to know what kind of questions they may get. What kind of things can we practice some scripting with each other that may give us confidence that we can still ask these questions in a safe way. So, and if that's not possible, maybe it looks like you have tried to pick out some of the questions, some of the questions to keep that stability there. But please continue to talk about that with your teams, and, kind of go back and forth of different things you can test in different environments. And I love scripting and role-playing with my teams because that's a safe way to do it if we're concerned about testing it the first time with a client. I like to do role-play with each other. So here's time for you to take out your pen and pencil one more time and reflect upon some recently discovered Pdsas that you may have now that we've talked about them. Maybe it has been scripting, chart template creation. Maybe you've created a new one. So, go ahead and jot those down if you feel like you haven't done that in a while. Another thing to consider is if a team member has some downtime. It didn't look like too many of you picked, that your hours were decreased or changed, but if you do have a team member or someone within your office setting or clinic that has some downtime now, does your team have a quote-unquote to-do Pdsa list, things that you've been wanting to get around to testing or trying, but, we've just been so busy in that Class 1 rapid, going with the flow, don't have time to do that. Maybe it's time to pull that list out. Maybe there's opportunity and time, taking on that EMR adjustment that we were really hoping to work out. Starting a manuscript talk, an abstract, maybe getting that data together that we have, creating a learning tool to use during a video visit. And then go ahead and note some ideas on how to communicate and celebrate each other now. If we need celebration more than ever right now, because it's just this, we're in, the twilight zone a little bit right now. So, and then also when things get a little hectic, our communication can wane because we're holding back a little bit because of the tensions and nerves out there, and we may feel that with our patients and families as well. So jot down some ideas that you may have about communication and celebration for frontline staff. If you have frontline staff that maybe you work with or supervise, or maybe you are frontline staff, if you are, how would you like to be communicated to? What would you want to know that just need to know? And how would you like to see celebrations occur? Maybe it's a bell ringing. Maybe it's somebody sends you a GIF, GIF, a GIF, or whatever they say. That's just, some cheers and balloons and yay, way to go. Leadership. How can leadership communicate successes or communicate learnings and celebrating each other? It doesn't have to be a huge hoopla. Sometimes it's a attaboy. Support staff, and then finally our clients and families. Communicating. What are we communicating with our families right now? Thinking back on those essential skills, essential parts of the visit, the well-woman visit. What are we communicating that even though we're on telehealth or even though we're on abbreviated hours, we still care about your health? So what are we doing there? How can we celebrate them when they make the appointment? That they're, making changes themselves because of COVID-19, and maybe it's helpful behaviors that they're seeing as well. I want to give you just a couple minutes to jot some things down, and if you feel so moved, I'd love to see some things that you could put in your chat. So Sarah brought up that she thinks that having her supervisors acknowledge the extra work, even in an email, is helpful. It's so true. And, again, seems like we're busier than ever. Those things you think, gosh, I used to be real good about providing little celebratory pats on the back, and now that we're not physically together, I could forget about it. So how can you remind yourself to do things that you know work and can encourage people, but now in this new environment? So thank you, everybody, for sharing. Take another minute. We got a couple more people typing, and I appreciate that because, like I said, this will be recorded, and I hope the chat can be documented and recorded because these ideas you're sharing are very helpful. Kathy brought up group text to check in with staff working, providing kudos or get help on resource question. Love it. Love it. Group texting. Yeah, I didn't even bring that up. That's kind of like a huddle, but virtually. Getting on that group text. And when you talk about spread, like we heard on that webinar last week, that is, our culture is very adaptable to texting and group texting, so it's probably not unusual for your staff workers to get that, and they can adapt to that rather easily, which can decrease your stress levels. Keep it coming. That's wonderful. So, it may take a minute, but I tell you, when you start thinking back, you're like, well, yeah, I did this. Think about maybe you were starting something new in January, a personal event. I know Sarah brought up, I heard her say something about playing guitar now, that she's taken this up again. And I bet she's done loads of Pdsas with that. Like, how much time do I'm going to practice on so many hours a day, and then we'll see how that works. And then picking music and, who do I get a tutorial from, and testing those things out. So all of that. So Joyce brought up Teams, Facetime calls to check in with everyone to see how they're doing and progress towards goals. So, Joyce is keeping that, that the language up at how, we will make progress during this time. It's still possible to make progress. It may be different kind of progress. Maybe not like we would have had if we were all full staff again or full capacity, but we are making progress. But keeping, yes, and Catherine's talking about keeping a Pdsa to-do list. And you may have a to-do list, but you never thought they were Pdsas, but most likely they're things you're going to have to learn. And you can keep going back. And yes, everybody wants to feel valued, Karina. That's so true. We do, because right now we need it. We really need to be hearing it. And clap for each other for all the work that we're doing for ourselves and our clients and families. So no QI Nerd would be complete without providing an infomercial about it. But these are some, things about quality improvement that I think are foundational, and I like myself going back and looking at them from time to time. But change and improvement are never easy, right? Pandemic or not. So keep that in mind. When we do improvement work, we are doing changes, and they're cultural changes and personal changes and motivational changes. So it's never easy. And don't chase the perfect for the good while you're learning and adapting right now. So it doesn't look the same, most likely, than what it was in January, but, don't make it doesn't have to be perfect. Look for the good in what you're doing and celebrate that. And always, you're adapting it, you're testing it, you're reflecting back on it. You can make adaptations to make it even, poor language, more good. A simple system we are used to can become even more complex when change isn't contemplated or introduced. So even something as easy as we know how to call people on the phone. We do it all the time. But all of a sudden it becomes complex when I have to call patients from our homes. It's a whole different level. So the complexity, even something simple, can become complex. And then our fundamental changes that result in improvement, there's a lot going on right now, but fundamental changes that do result in improvement are alter how your work or activity is done. It does produce positive differences in results compared to the way it was. You're seeing a difference. It's not the way it was, but it's positive differences in results. And those changes have lasting impacts. And one last thing, the possible secondary impact. Have you thought about this moving forward with your CoIIN work, your preconception CoIIN work? Showing this work as generalizable to other situations of stress and the opportunity to push out emerging practices. Maybe something you are doing is one of those emerging practices. Maybe something that you are doing is generalizable to other situations of stress. Not a pandemic, but when else? Flu season in general. The time that families are contemplating having a family, that can be stressful too. So, thinking about that's really exciting about this time, is looking at our work and making sure in that documentation that we have those things that we could possibly have a secondary impact. And we also have got a comment, taking time and area with decreased workload to brainstorm ideas for a new program. Heck yeah. That's, taking advantage of the time. And you're using the stressors of this time, and not all stress is bad. The stressors of this time and the energies of this change, constant change, I bet you are finding that your brainstorming was even more productive than usual. You came up with some new ideas based on some of the learning that you're going through now. So wrapping up here, why Pdsa now? Well, we brought this up earlier, but I've added a few things to this. So rapid learning during rapid time. So again, we're going to think about smaller scale or even prioritized testing. Maybe we were testing all the clients that came in. Maybe we were asking the intention question with everybody because it was embedded, and we can't do that now because we're having to adapt too much of our workflows. So I'm going to do smaller scale. I still want to test this. I still want to see how effective those things are. How can I scale that down? Smaller tests for higher risk times and events. So that may mean something like one patient and one observation, but the learning is still there. Maintaining staff momentum. You are still learning and contributing. And so bringing that learning up celebrating. That can keep people's will up for why we're doing this work. We are innovating very rapidly right now, so make sure to jot it down and share it. And it's a sound practice. It's science and theory-based, your Pdsa cycles. So the good part of all this is a quote I just recently got from a colleague, and I had to write it down because I was like, oh, and I'm sure you've heard things like this, but I love this one. One of my best memories from listening to my cardiovascular surgeon father-in-law, who triaged care during World War II's D-Day, was what innovations the extreme circumstance allowed them to try, to do, what they learned, and what good things actually stayed in place afterwards. Just think about that. We're in our own little D-Day right now. And either something you're doing or you've read or talked to somebody, have you heard about these things? Think about what you're being allowed to try that you maybe would not have been allowed to try back in your office or your clinic. What you're doing and learning and what good things could actually stay in place. Those good things could be for employee engagement or joy in work. Could be for improved outcomes of client care, outcomes of our moms and our babies, outcomes for access to care. So lots of things that can, this is the hopeful part of all of this. So we've gotten to the end of the river. It's back down pretty smooth again, and we're pretty happy because we did good. We are continuing to learn. We shared that learning with each other. We celebrated that learning, and we made it. So thank you. Thank you for that.
Thank you, Mary.
Yeah, thank you so much. I have to tell you, the river analogy definitely really hit home for me. Thinking about kayaking or paddling through various levels of whitewater. So definitely was really helpful in framing this. So thank you, Mary. I'm going to give opportunity for folks to chat in any questions or comments that you have for Mary about this topic. She's such a wonderful resource to talk about, what you're doing right now, if you have things that you would want her insights on. Mary, I have one question for you, and I have a feeling it'll just fit really well, but, as folks have experienced disruption and you get back into that routine, are there any things that you recommend, thinking about our sites and the different types of screening that they've implemented to help, kind of build that momentum again, to make sure that there is some sustainability and maybe some testing to see how things are going?
Yes, I agree, and I think you kind of said the answer within your question. This is what I'm thinking would be a recommendation. There's all sorts of things you could do, but
Mary, I think we just lost your audio. Maybe your headset unplugged? Mary? While Mary's working on reconnecting, while she's working on reconnecting, do take this time to chat in any questions or anything like that. Ooh.
Okay, I'm back. I don't know what happened. I got cut off.
Okay,
welcome
back. Thank you.
Yeah, thank you about that. I really, this is why communication is key, that you as your core team and even with your leadership, because we talk a lot about, in quality improvement, having that leadership support to remove barriers and things like that, having some discussions before you go back and at full capacity and even at part capacity, if that's what it's going to be. You need to have discussions about the way it is currently, what you've learned, how you've adapted, what's missing. Maybe there's data you were collecting that you haven't been since you've been out, so you want to do like a snapshot. Can we just pull 20 charts and just kind of look and see what's there, unless we know it's been zero or zilch. Testing, you're going to have to use Pdsas just to get back into that again. So having conversations, number one, about what we've been doing, what we've seen has not worked, what we have seen that has worked, because those may be bigger business decisions about what we talked about earlier, those secondary wins or the things that we'd want to stick around. And then if we do just go right back, it's going to be awkward for all of us. You know, many people are already having some anxiety about going back. You know, what's that? Because it's loss, it's change that we're having to deal with on a human level. So that's when you need to, you know, that's when the Pdsa can be very comforting because it's a small test. So it's like, okay, we're not going to go back and all of a sudden see 50 clients on Monday and ask them all over again, unless we know that that process and that procedure was pretty ironclad. We have the same staff, we have the same conditions, we have everything, and it really is like riding a bike. Going back on it again, no problem. But most likely after discussion, you may have to make some adjustments in workflow. Like you may have patients coming in different doors now. You may only allow so many still in the waiting room. How are we going to deal with that? And are we doing half telehealth and health inpatient? You need to think about these things before you go back. You will be happier for it. Maybe you can split up the testing as well. Say, you know, someone on the team is working just on one thing and someone else is working with the paper products. One person's working with the EMR product. Maybe another person is doing the teaching and because it's remaining in a different way. Again, all of that requires some planning ahead of time, looking at your gaps that you may have going from home to you know, from COVID's restrictions to lightening up. Where's the gap still? And then what can we do individually and as a group to continue that work? Your celebrations, you're looking at the data, things that you should be doing all along because that's part of your momentum as well. That's even more highlighted. So you may have to reach out to your leaders and say, hey, you know, when we come back, it's going to be, you know, kind of stressful at first, you know, really appreciate if you would, you know, just remind us that why we're doing this. Or read your aim statement at the beginning of your staff meetings again. I love how Sarah and Catherine do that. They bring up the objective at the beginning of the webinar, why we're doing this. You know, remind everybody about that. That helps continue that momentum and will for the work. And reminding us that, you know, this break wasn't a waste.
Thank you, Mary. I think that's just really helpful, and I think it's got, like you said, a lot of application for all of us, both within our CoIIN project and within our work in general, in terms of thinking about what that means to go back. I think kind of just two more quick points. You know, one, and I know several folks that are listening, and we had a conversation kind of in the middle of all this to think about, okay, what's going on, and there may be some really cool opportunities for us to be exploring over the next few months together, thinking about, well, how could telehealth actually enhance or improve our capacity to provide well-woman health services in terms of convenience, or how is that relational for women in a different way. So I think there's something to explore. I know that, and I think it's in Oklahoma, we're doing some creative innovations around contraceptives, and how you were giving those out, and heard this from some other folks, and ways to actually make it easier and quicker for the time, but also maybe an adaptation that would be really great for clients. So I think those are some things that I had heard from everyone. And then also just a note for all of our CoIIN partners, so that we still get to work with Mary through the end of September. And Mary is available to meet with your teams, or your clinic team or your state team, and kind of actually help you work through some specific problems that you may have. So I wanted to remind you that Mary is a resource for everybody.
Yes, and just Mary again, I just wanted to say that on that, through some brief discussions, there may be particular QI tools that would be very helpful in your planning other than just Pdsa. There's a lot of other QI tools that, depending on what your needs are, that could be very apropos.
Thank you, Mary.
Thank you, Mary. I'm going to clap.
Oh, thank you.
Yay! We appreciate you taking the time.
We appreciate that. And again, appreciate that we were able to bring you in on this call and remind everyone about what a great resource that we do have with Mary's time dedicated to the project. So please take advantage of her excellent expertise. So just wanted to take just a few minutes. We definitely are not going to go all the way to the end of our hour and a half, but just wanted to talk a little bit about some of our CoIIN next steps. And this is really difficult to do in this forum, and we acknowledge that. And so some of these may be some food for thought. You might chat something, but it may be something for future conversations. But as we're thinking about our next steps, so we are crazy in May, and our project formally ends in September. And so the one thing that we are all embarking on together, and I saw some folks from Delaware on, so they're up next, is that we've been creating our state stories. And over the next several weeks, we're going to be taking those stories and creating a collective CoIIN story to really think about our shared journey together. And we will share that with everyone, and I think that's just kind of an interesting process in and of itself to look back. And I think when we get to a collective story, there's an opportunity for us to kind of come together and brainstorm and think about, well, what are some lessons that we have learned together that we think are really important to amplify to other states that are working on the National Performance Measure on preventive visits for women with other clinical partners. So I think as we have our collective story, that allows us to be creative in thinking about how we might want to share that, and also to be thinking both in your states and on a larger level, what are some key things that we would love to see move forward. So that is definitely underway. We were also thinking about what are some opportunities to leverage change through this time. So some things that we've noticed is that more people needing to take to social media to be able to communicate with their communities, communicate with the patients and people that they serve. So is there something around some of these changes that have potentially loosened up some of the restrictions and how you use social media or brought some questions forward? And is that something that some of you might want to come together and explore and talk about a little bit? We've talked some about adjusting for telehealth, and I think that there could be some really great opportunities to be really creative with how this could be a way to extend preconception counseling for folks that it may be difficult to get into a clinic from that usual 9 to 5 period of time. So I think coming together and looking at what are the things that worked really well, and I think the same for many of our partners are also doing care coordination and navigation with women. And so I think it'd be really great if we could have a session sometime for an hour where we could come together and have that conversation together about what we learned. We also heard, I think it was from California, about maybe this is an opportunity to do some different online group supports. We know that when we bring groups together in person, it can be very complicated for people with childcare and transportation and getting to the location and all that time it takes, whereas some folks are finding that they've had a really big uptake in kind of group support and conversation. Is that a space that we might want to work? And then I think for all of us to continue to think about how has equity been a thread, or how have the things that we've done either focused on closing disparities and closing gaps, or are some of the things that we think are a great idea actually good for some people but not for everybody, and in particular not the people that need them most. And so I think as we think about some of these opportunities for change, that would be something to really explore. And also Mary brought up, let's not forget about the voice of the customer. And so as we're hearing new themes and new ideas around services or gaps, like we've got some training in human-centered design. So maybe not forgetting that and doing some of these smaller opportunities to really listen to what folks have to say before we either throw out something new that we've done or decide we want to keep doing it. That's a really great point, Mary. And then Kay, it's so great that you're on, Kay Johnson, talking that she's working on policy change and collecting ideas and experiences. And that was certainly something, as you see, that we were thinking, how might the changes that need to be made, what are the things that need to happen? And so certainly policy issues are likely to be something that needs to be addressed as we go through this process, and to continue to lift up Kay's voice. And we're going to need advocacy as states begin to cut budgets. Both Washington State and California have had governors pull back from investment in postpartum care, and other states will follow. Even if you cannot advocate, sharing experiences with those who can makes a difference. I think that's just going to be really key. There's both that positive of advocating for changes that we'd like to keep, but then also those concerns about pulling back investments that we think are also important for women's health. So Kay, I'm so glad that we have you as a consultant on this project, and it definitely sounds like that would be a conversation that we might want to think about having. And then just thinking about kind of the structure of providing care, when we think about how we disrupted everything so quickly, which all of us, I feel, just take a pause for a minute when we think about the massive changes that we've experienced. I know I was talking to colleagues with the Nurse Family Partnership Program. They went from 9% of kind of televisits to 90% in 2 weeks. And I know our Healthy Start partners have done that as well. That's pretty significant. And so I think, as Mary said, just going back to the way it was, we lose a lot of the richness of what we've learned, and maybe lifting up some ways of disrupting old patterns of thinking that allow for something new. I see some folks typing. I really don't like this format because people can't now talk back. I don't know if people have something to say. Catherine, if people can call in or say something.
Anybody who's on the phone, just unmute yourself, and you're welcome to chat. And if you're on the voice through the computer, let me know, like raise your hand or chat me, and I can unmute your microphone.
Yeah, I would love to hear, like, if any of this is resonating with you as we think about the time that we have left together, and some kind of shared learning or conversation that we might have. Or does these look like they're kind of in a direction that is of interest to some of you? I think we have people from every state on. What are some of your thoughts? Don't be shy to just jump in.
Yeah, feel free to unmute yourself and speak up.
We have an awesome policy conversation on a chat with Milton Kay, who are some of our PCH policy leaders, which is very exciting if you want to look at that. But others, I mean, I would love to hear if anyone wants to kind of like amen, so to speak, any of some of these opportunities that you think would be great for us to explore. Some folks typing. I can tell your brains are all
about what social media platform used for education, advocacy, et cetera, how that works, and what doesn't, what's well received. I know, Rocio, you were talking a little bit about flipping or getting up to speed on Facebook Live, I think, and others have probably used social media a good deal as well.
Mm-hmm. Yeah, this is
Absolutely.
Mary. I was just thinking that, a lot of times in healthcare, we've been kind of scared to use social media for, obvious reasons. So I love that folks are getting into it and finding ways to make it work to either, for another point of access to people. I'd love to hear more comments about how that's going and how they got away from any fears that they may have had in venturing there.
Mm-hmm. And Ellen, thank you for your comment as well. Monitoring data will be essential. Fetal infant mortality, FEMA rates, birth outcomes, STI rates, unplanned pregnancy. Data can support both decisions and practices for advocacy. I think that's really great. And thinking about some of the screening tools that you are all using with your clients, it may be that you're finding increases in certain areas, say mental health or binge drinking, that might also guide some of the programs or some of the direction for some of the work that you may be doing as well. It's been very stressful, and it can be hard to reach to your highest, best coping mechanism when you're under a lot of stress. So I think that's another way to think about data as well. I'm sorry for some of the typos on this slide. We just asked for grace. We're working a lot these days. But some of the other things that we were thinking about, and this came up really with California's call yesterday, and Kiko really elevated this question of, so really now as we're getting into halfway through year 3, what do we mean by this community engaged? What is that about? How are we involving community in our projects, and how are we working with them to kind of share resources? And I think for us, we have several Healthy Start sites, and I see Healthy Start in particular as a real leader in this space for our CoIIN. But is that an area that some of the different projects or states might want to be really thinking about, kind of how are we doing that kind of clinic-community connection? Something that Oklahoma has brought up, and I think also I've heard this from North Carolina, is, how do we bridge our CoIIN work to maternal health initiatives? So for those of you that are looking at your maternal mortality and morbidity reviews, are really identifying the need to get upstream and address women's health before pregnancy. I think in particular folks with chronic conditions and including some mental health challenges, how do we get upstream and really work with women before pregnancy? And I think, how might we be able to leverage our work with this project together? I think that was a conversation that we really are hoping we can have, hopefully when we can see each other in person in September. But that might be something to be thinking about now. And then finally, how are we going to sustain and scale and disseminate the work that we're doing? So this might be within your state, so that you've, like Oklahoma has worked with 7 clinics pretty successfully. How might you think about working with 21? The same in some other states. How might you increase those? Are there other strategies that you have for really sharing what we've done in our different states? So I think there's a lot of really cool work for us ahead, and just, really, again, curious where some folks might want to jump in.
This is Milt. Can you hear me?
Yes. Yeah, Milt.
Oh, hi. So my phone got a little cut off, so you might have answered this. I was trying to type it in. You mentioned, and it may relate to this last theme of how do we work with communities, but you mentioned that 2 states had cut back on their postpartum care or women's preconception care in this period of COVID-19. I was in California and one other state I heard you say. Did I hear that correctly? And could you or Kay or anybody on the phone comment about why you think governors are pulling back and how we can think about this, because this is how among ways we could relate to our community?
I think that was Kay's observation. So she's typing. I do not want to speak on Kay. I think
my phone got cut off, so I
that's okay.
I switch to cellular. To just talking.
Catherine, can you unmute Kay, please?
Kay, you should have a microphone right now. You may have
it looks
to,
like you're good, Kay.
You may have to select audio at the top of your screen to unmute yourself or connect your mic as well.
Let's see. While she's doing that, I also wanted to note that she also had us think about how might perinatal quality collaboratives be potential partners for us in this next stage of work. And Corinna Jackson with Healthy Start notes that they are in medical homes, so that gives them access to lots of different types of, I'm thinking, providers, partners that you can collaborate with.
One more try.
Kay, did it work?
Can you hear me now?
Yay.
Yeah, cool.
Take it, Kay.
So there are two things going on. One is that states are going to have these tremendous budget cuts. And the dilemma with things like these postpartum initiatives is it's kind of a last in, first out. It's like the last hired, first fired problem. So the very progressive governors in Washington State and California made a big commitment for a new initiative around postpartum support. And they don't have any money for new initiatives, and they're having to cut to the bone on other things. So those programs, they actually even expressed regret, but said they didn't do it. They couldn't do it. They don't have the money. And then we're going to have conservative legislatures, Michigan, Wisconsin, other places where they're fighting, against the whole strategy, but they're going to have to make huge budget cuts. And they're going to be cutting into the Medicaid budget. They're going to be cutting into the health department budget. And it's something that I've working on that Milt knows about. Let's just say there's $2.5 billion in Title V matching funds that are on the table that any state could go after, either administratively or legislatively. I just think paying attention to what's happening, particularly for our populations, and sharing our stories is going to be critical.
Can I just ask, Kay, is part of this the cost of COVID? That is to say, states not getting money from federal government to reimburse for their high costs are going to force them into have to making these drastic cuts. Is that the dynamic that's actually happening? That's
one huge dynamic, and one reason why they'll go looking for other health dollars. The second is that maybe the visit to the mom isn't seen as essential, whereas they send the money to the hospital. So what's the purpose of the money? This whole image that everything important is happening in a clinical setting. And then the third one really is just revenues. Sales tax are down. Rooms and meals tax are down if you live in a state that thrives on tourism. Nobody's paid their income taxes. States are broke.
Yeah. So I just wanted to. Go ahead.
Sorry, this is Diana Ramos from California. And I just wanted to say that we're in a $54 billion with a B deficit. So, that's the reason why there's cuts that are being proposed in all programs, not just Title V, MCH, and the perinatal health.
So this is Milt. I just want to encourage us. I mean, we're in for a terrible time. There's no question about it. And public health had been losing a lot of money anyway, but here, this is a public health crisis. COVID is not clearly only a clinical crisis, even though some of it's been portrayed that way. It clearly has infectious disease aspects to it, but it's also a social determinant of health crisis. It's an environmental crisis and possibly a moral crisis to think about the four crises that we're facing: infection, social determinants. But I think we need as a community to obviously participate with all the other sectors in public health and saying, if we learned anything from this crisis, is that public health sector needs to have greater investment in it. We also need to be helping people see that COVID is a multifaceted catastrophe and pandemic for us, and that really particularly new moms and new families that are trying to conceive babies, have babies, plan babies, in this period are really being hit very hard emotionally and mental health-wise and really in every possible way. And there are particularly a community that's been particularly hard hit by the COVID. And that these are we need to be making arguments that help people see the importance of our community. I mean, every community is going to say the same thing, but this is our community, about how the COVID is actually impacting this particular community in really complicated and difficult ways. It's often, as Kay said, here are progressive governors. We're putting really good proposals forward in pulling back, and many of the hospitals have pulled back in terms of, and healthcare have been pulling back about what you can do during this period. We're hopefully trying to figure out some positive things about how telehealth can actually help us and not only harm us in this period, because I do think it will help us in the long run, but I think we have to make some political arguments, and I'll stop. We have to be thinking about how to align ourselves politically with other groups that are arguing for increased funding for prevention and public health and prevention. And I happen to think birthing is one of the topic areas, both preconception, conception, postpartum, that is really being drastically impacted by COVID. And we have to remind people about that. It's not just a viral disease. It's a pandemic that hits many different sectors. I'll stop.
Thank you. No, thank you, Milt. And I wanted to lift up some things that CoIIN is talking about in terms of both Healthy Start as being, again, a real pulse point on the community, and a group that I think, as we're thinking about how we can make sure that care coordinators and clients and clinicians are all on the same page, that there's a lot that we can continue to learn from them. And at the same time, she talks about how it's really important for Healthy Starts and all of us to really be in tune with ears open, and also thinking about how we tell our story. And I think Kathy also underscored that, and noting that there's some attention more to whole health, including mental health supports and social and emotional support and impact on health and family relationships. And I definitely agree with that, Kathy. I feel like we've seen a lot more conversation around mental health and well-being in a way that we haven't seen before, and that's an issue that I know many of you have identified as a key issue for people of reproductive age in particular that's often not looked at. So I think, again, there's both that opportunity for some new areas to explore, and then, again, the partnership that we've created here together to really to stay connected and tell a complete story. And so I think it's really important. And then I think someone else, I think it was Kathy, also mentioned that, like, this is not the time to lose momentum in terms of what we're doing. And I think also, as we were saying, continue to think about when sometimes systems need to be disrupted. So I know some folks have said, well, it's not like things were so excellent, pre-COVID. And so where are the disruptions that are actually going to be the fissures for change? Kay's noting that she's been saying that advocacy may be as important as self-care, and that someone said that their self-care is doing advocacy. And so thinking maybe about how we can do that, appropriately with the HRSA-funded grant, and also in our own lives is really important. And then finally, I think also, and Kathy, Corinna, and Kay, y'all are on fire, and Milt, thank you. But I think that also something we've talked about in North Carolina on the early childhood front is, like, is this an opportunity for once and all really, really, really demonstrate how the social drivers of health are so related to outcomes that we want to blame on individuals? And so is this a chance to really narrate a different story? So
pandemics,
I think
just
this is
to
all.
say, okay. Pandemics bring out the best and the worst in communities, and they exaggerate all the existing faults that we've had, the underfunding of public health, lack of interest in women's health. These things all resurface the social disparities. I mean, who's getting sick and who isn't getting sick are really heavily socially determined. So yes, it's a sad way of showing how social determinants are making an impact in terms of who's dying and who has to still work. But I do think particularly, so I don't want to lose that point, but I do think we have to think carefully about ways in which there are progressive elements of how we respond to this, like trying to make telehealth a more useful intervention for our work, and how to get messages out. Like all of today's presentation was about messaging and how to, among other things. But we also want to be careful that in the retreat back, we don't retreat back in women's health to one that has such heavy racial and class basis. So progress about bringing people into prenatal care and delivery and helping in preconception, pre, during, and post, that we don't return back to a situation where it's a very narrow set of interventions and heavily influenced by people's social class and race. And I worry a lot about that during this period because the pandemics also reveal that very strongly. Having said that, there are a lot of great groups doing some fabulous stuff. So there's a lot of positive things happening, but there's a lot of danger, which is why I asked you about the cutbacks by our most progressive governors, not our least.
Well, thank you, and thank you for all the great conversation on chat. So, you know, it sounds like we have lots that we can still be in community with, and perhaps we can also put together a variety of ways that maybe some new and creative ways that we can connect across states and interest areas with some smaller groups of us that really want to continue these conversations. And I like Kathy's point that crisis can be a dangerous opportunity, and I love to hear you unpack that a little bit, Kathy, because I see that as both opportunity but also dangerous opportunity. So I think, yes, and I think for all of us, it's easy that, as we, Mary really kind of reminded me that it's amazing how we can adapt in some ways, and so how do we continue to kind of have being off footing be in a way to be pushing for change. And also never believe me when I say that we're not going to go all the way to 2:30. So not wanting to overly shift, but keeping an eye on time, and kind of going to this communications piece, we were able to get a little tiny little bit of funds from ACOG to actually help us for the next few months be able to be boosting some Facebook and Google ads to be getting information out there about women's health, which is a really nice opportunity, and a few hours of help for Suzanne in order to be able to do that. And so, Suzanne, I just wanted to give you a minute if you wanted to talk about some of the communications where we still have everyone together. And also just as Suzanne has her beautiful special little small coworkers there in case you hear them. Here you go, Suzanne, take it.
I do, so if you hear little voices in the background, I usually will say it's me and the team here. But yeah, we look, I mean, you've all heard the Show Your Love Today redesign, and our team really, you know, leaned in to make sure that that content was all updated on the knowledge section and that there's new products that we can be showing. And so with some of these resources, we're really hoping to, you know, kind of how we had before, we had an entire engaged ambassador network, you know, lifting young adults' conversations, their own healthy messages from their own channels. So this is really allowing us an opportunity to you know, showcase new faces, different communities, create little micro-influencers on our page. And, you know, something that we, you know, we're so thankful that our partners are continuing to promote and show Your Love Today, and we have a partner that still is going out around their community and testing Show Your Love Today website, just with different groups of young adults to hear how, you know, how is the language, what are the images, what do you think? And so, you know, something that we've continued to hear is seeing real photos. They're not stock photos. You can tell that those are real young adults, and that the words that are on the, you know, the messages on the social media are real stories of real people and that are making connections with each other. So we're continuing to do that, all driving, as Sarah said, we have money now for promoted social media and Google ads, which we never have before. So we were able to do all of this prior. We've done this all organically just through our partners and really just trying to be creative, you know, in promoting, and now we have a chance to put more money behind it and to put money behind community voices especially. And so we're really excited to have that get started.
Thanks, Suzanne. And so these are images. Yes, absolutely. So again, if any of you have within the different clinics or sites, want to have anyone really continue to connect with Suzanne as we're developing messages and amplifying them, I think that would be really great. So I just wanted to lift up that work. And then just with an eye to time, wanted to let you know, thank you, Suzanne, about some upcoming webinars. Catherine or Erin, Catherine, do you want to talk about the
Happy to. Yeah, this is Catherine Bryant. I know that some of y'all have had the opportunity to receive past training from Patty Kaysen. She is going to be doing a webinar series that's focused on contraception, which will be available in the near future. There's going to be 3 pre-recorded webinars, as you can see listed here below. And then coming up in a couple of weeks on June 5th from 12 to 1, there will be another Contraception Update 2020 webinar talking about best practices. And there will be a lot of opportunity in that webinar for Q&A and discussion. So we do encourage folks to watch those webinars on our Before and Beyond page. They'll be posted, we're planning by early next week, and we'll get that link out to folks and encouraging folks to watch those in advance of the June 5th webinar so that you're able to connect with Patty about any questions you may have about that content. So those are some little webinar series that we have coming up. And for those of you that missed it, already archived on Before and Beyond, as Sarah mentioned before, is Ken Harris recently did a webinar presentation for us focused on connecting and building community in this new virtual space. And I think that as we're all making these adjustments, doing these tests of change, as Mary was talking about, that's a really wonderful webinar to also include and help as you're trying to get used to this new normal.
And just real quickly, pre-recorded webinars, they're only about 15 minutes long, each of those. So in terms of pre-watching them, it's not super long, but will be a lot of great information on those specific topics.
Thanks, Erin.
And this, yes, thanks, Erin. And then also, I think after you watch those, I know that Patty's been to do some workshopping in North Carolina and Oklahoma. And I think if you really want more of that, maybe in the future, we would be able to support, kind of Patty working a little bit more with your state teams as well. But this way, I think it'll be a really some good updates for everyone. And we're excited that we think the quality is going to be really good too, because she happens to let her partner's actually like a music producer, so very exciting. So that's what we have coming up ahead, and I think we wanted to kind of think about the next few months of this project based on some of the future directions that we had mentioned. So this is our aspiration and our hope and our dream, because we really want to go anywhere but our houses. We have been able to book the same location in Baltimore, Maryland in September for our in-person meeting. I really want to appreciate Catherine for being a very quick thinker, and when I was feeling really overwhelmed in March, Catherine really kind of jumped in and managed this contract. So far we haven't lost any money on this contract. They let us take the exact same thing and put it in September. So we will, of course, together monitor the trends and the travel. And, we know that this may be a dream that we could get together, but we did want to let you know that we have reservations in place at the same place in Baltimore. And so if you wouldn't mind to hold those dates, hopefully we'll be able to be together in one place. So I think that's it. Hoping that we will send out an evaluation, and would love to get your feedback on that evaluation, also about any direction that you think we should be going, if you think that we need to start some small little discussion groups on some of these topics, or you'd really like to see us leaning into one particular area as a TA team. We would love to really hear from you about how we can best serve you. Anything else, Catherine, Erin, Suzanne?
No, that's it. We'll be sending out a follow-up from these sessions that will have this evaluation link. and we really appreciate everybody adjusting, knowing we were planning to be in Baltimore these 2 days and making time in your schedules to join our transition to a virtual meeting. So thank you for being engaged and taking the time.
Yes, and Team Delaware, we will be seeing you at what time, Catherine? 3 o'clock?
In 30 minutes.
3 o'clock. So Delaware, we'll see you soon. Everyone, thank you. Sending you virtual hugs and high fives and much gratitude. Mary, thank you again for your presentation today. And everyone will be following up soon and sharing all of the wonderful stories that you have created with all of you.
Thanks, Sarah. Be well, everyone.
Thanks, everybody.
Bye, everybody. Have a good evening.
Bye. Take good care.
Thank you.
Thank you.